Nanophthalmos is a rare eye condition characterized by short axial length, high lens-eye volume ratio, thick sclera, angle closure, and high hypermetropia. Nanophthalmic eyes have abnormal collagen fibers in the sclera, which contributes to impaired vortex venous drainage and predisposes the eye to uveal effusion syndrome. Because of its anatomical characteristics, nanophthalmos poses a significant management challenge for all ophthalmologists. We came across a 70-year-old female patient with angle closure glaucoma, short axial length, and a very shallow anterior chamber. On gonioscopy, we found out the angles were closed almost 360 degrees. The RCS complex was thick, around 2.5 mm, as noted on B scan. Cataract surgery with custom-made IOL implantation was planned. IOL power calculation was done using SRKT and Hofer-Q formulas. Patient underwent in the bag IOL implantation of a 50 diopter single-piece hydrophilic IOL with surgical PI. Preoperatively, IV mannitol was given, and intraoperatively, care was taken to prevent sudden decompression while operating by using good amount of dispersive and cohesive OVD. The anterior chamber is quite shallow. Maneuvering in the anterior chamber can be difficult. Frequent use of dispersive viscoelastic can be useful in such situations. There is high tendency of iris prolapse through the side port as well as to the main port. Plus 50 diopter IOL can be quite thick in the center, so injecting this lens in the bag can be quite a challenge. It's always safe to enlarge the incision, and it's better to avoid the butterfly cartridge. Surgical PI can be done either using vitrectomy or can be done manually. Here, surgical PI is being done manually. 5 days postoperatively, patient presented with shallow diffuse choroidals. We diagnosed it as uveal effusion and started him on oral steroids. 10th day postoperatively, patient came with pain in eye, rise in intraocular pressure, and further shallowing of the anterior chamber. We diagnosed it as aqueous misdirection, uveal effusion leading to aqueous misdirection. Our diagnosis was confirmed by doing UPM. A 25 gauge pars plana anterior vitrectomy with zonulocapsuloiridectomy was planned for this patient. Communication was established between the anterior and the posterior chambers, allowing the free flow of aqueous between the two chambers. Creating the communication between the anterior segment and the vitreous cavity is needed to resolve the problem. These are the pre- and post-operative anterior segment OCT showing opening up of the angle after the surgery. At 1 month follow-up, patient has improved visual acuity and maintains intraocular pressure of 14 mm of Hg without any anti-glaucoma medication and has a deeper anterior chamber. The take-home message is, while operating on a nanophthalmic eye, be extra careful and also be ready to detect the complication and intervene.